Okay, so now let's recap shock. I'm not going to go into every detail, but I just want to do an overview of some important tips on that. So again, we need to think about the pathophysiology of shock. So you should know your physiology about how the body's normally processed, but now we think about shock and what's happening to the body. So think about this. Tissues and cells. What's going on when your body's in shock? Your cells are not working correctly, right? Your tissues are not getting blood or electrolytes. And what are tissues? Tissues are your organs. It's basically your makeup of your body. So what happens if you're not getting any blood or electrolytes to these tissues? What if the cells are dysfunctioning? They don't work. They end up failing. So the common theme here is tissue perfusion. If you're not getting tissues reperfused or they're not perfusing correctly, they're going to die. Hence would be multi-organ dysfunction syndromes or MODS. Once you get to that, it's not a good scenario. So any of these shocks, you can go into MODS. All right. Once you're in, if you're greater than 2 organs are failing, it's a high likelihood of fatality because all of these become wrapped around tissue perfusion. So we know there's different types of shock. So we have cardiogenic, which a lot of times is from heart attacks. Because remember, if you have an MI, you're not getting blood to a certain part of your heart. So if it's a major MI and it's one of your main arteries that supplies, like say the front portion of your heart, those cells are dying. You're not getting perfused through the heart. And so if the heart's not going to pump, then what's going to happen? It's going to cascade to other organs, like your kidneys, which is why it's real important to monitor BUN and creatinine, because that is an early sign that something could be going wrong with organ dysfunction. Hypovolemic, diarrhea, fluid loss, sometimes from trauma, it just depends, but definitely trauma and fluid loss. Anaphylactic shock from eating shrimp, peanuts, bees, something you're allergic to. It's a hypersensitivity reaction. And sepsis, we always think about influenza turning into sepsis, so we want to prevent sepsis. There's a lot of protocols now in emergency rooms. And then neurogenic is a lot of times from trauma, C&T, T-spine fractures. It's really common for that. Now, obviously, you will see these anywhere in the hospital. Obviously, if you will see trauma more in the emergency room, but any of these other types of shocks you can see everywhere. That's why it's so important to really know what these are. So we talked about cardiogenic shock. We're going to talk about treatment in a minute, but hypovolemic shock, your blood volume's too low, anaphylaxis, allergies, infection, septic shock, neurogenic, think nervous system. So you have damage to the nervous system. So what is distributive shock? It's a type of neurogenic shock, or neurogenic shock is a type of distributive shock. Let me put that the other way around. So it's a triad of low blood pressure, bradycardia, and then what happens? You have peripheral vasodilation because you have severe central nervous system damage, usually from trauma or high thoracic cord injuries. So make sure you understand what that is. Okay, so I'm going to start at the top again, cardiogenic shock. So that's the only one that does not necessarily have a fluid loss. So treatment is different. So you don't want to right away think, let's give fluids, because if your heart's not perfusing well, it's not going to take fluids very well either. So you have to watch fluid intake and perhaps limit it. You don't want to overload the heart. All right, so I'm just going to say right now, no fluids. Okay, so what do you want to do with fluid? What do you want to do with the heart? Again, we're thinking that this patient probably had a heart attack. So we probably want to treat with some diuretics to get any extra fluid off that may be on, pressor agents such as phenylephrine or dobutamine is another example. So there's about 4 to 5 different types of vasopressor agents. You don't need to memorize the drugs other than just be familiar with just the names of them. All right, so why are we doing this? Vasopressors, what do? They augment the coronary and the brain blood flow when you're in shock. All right, so what it does is it blocks alpha and the beta adrenergic effects for persons with cardiogenic shock. So it actually improves it. The heart's not pumping very well, so what it does is improves the cardiac contractility, makes it pump a little bit better. And the preferred one is dopamine. If you have low blood pressure, that'll really bring the blood pressure up. But dobutamine is another good choice, as well as phenylephrine and some of the other ones that are out there. And epi is also given too, obviously. So just remember that. Now, why are we giving, also morphine can be given. Why are we giving morphine? Because it's a vasodilator. Why are we doing that? Because we want to increase the contractility, not decrease it. But actually, morphine relaxes vascular smooth muscle, and then it reduces the increase in workload. So it actually improves blood flow and improves cardiac output, which is why this whole triad of medications are really good. All right, you're going to give diuretics, meaning loop diuretics, to take some of the extra fluid off. You're going to give some morphine because we want to relax the smooth muscle, get that blood flowing. And then you have the pressor agents on top of that to increase that contractility, to get that heart pumping again. And diuretics, as we just talked about, it would be a loop diuretic, which would be furosemide is the main one that's used. It decreases plasma volume and peripheral edema. All right, so you're going to see that extracellular fluid and plasma volume initially decrease cardiac output, blood pressure, and then an increase in peripheral vascular resistance. But you need to continue diuretic therapy because then the volume and the vascular resistance will return to the pre-treatment level. So it's really good to give that. Okay, so I'm going to recap this. Cardiogenic. We're going to put on morphine, vasoactive drugs. Morphine, we're going to give diuretics. Okay, that's what we're going to give for that. I hope you can see that okay. I've got a big whiteboard here in my office. Okay, now, hypovolemic. Remember, they're losing blood. They're not getting blood. So how are we going to treat that? We need to reverse it by giving fluids, right? So what kind of fluids are we going to give? So it's going to depend, but usually we'll give crystalloids first, and then whatever else is in balance, we can give some colloids, which is albumin, for example. So crystalloids are very important, which would be like your 0.9 or lactated ringers. And then colloids, so make sure you review that, such as albumin. Because why? We want to get that fluid back up. We want to normal volume this patient, right? We want to get things back to normal. And obviously we'll find the cause of it too in the meantime. So is it from a severe infection and they're just so dehydrated? Is it from trauma? So we need to treat that, but you also need to be doing this in the meantime because we don't want this patient to go further into no perfusion or much decreased perfusion to turn to MODS and then fatal and then death. We don't want that. Okay, now septic shock. Oh no, anaphylaxis. We're on that one. Anaphylaxis. So with anaphylaxis, what happens is, let's say you got stung by a bee. Your throat starts closing up if you have an anaphylactic reaction. All right, your throat starts closing up and your vessels dilate. And with this, these are the people that have EpiPen. So epinephrine, that's a vasoconstrictor. It's a potent vasoconstrictor. An alpha adrenergic medication. It's giving you adrenaline. All right, so you're going to give epi. But you think with epi, what is that doing? Well, if you're if you are stimulating the sympathetic nervous system with this medication, what's going to happen? You're going to constrict the vessels. So it's going to get that heart pumping again, but it's going to dilate your bronchioles. So it's going to open up those airways. So remember, if you can't remember, go review the sympathetic nervous system and what epinephrine or adrenaline does in your body. It obviously works with the parasympathetic nervous system, but in this case, with epinephrine, this is what we need to do because we need to get this patient alive and we want them breathing. All right, septic shock. What is prevention of septic shock? Catch it early. You want to catch this stuff early, which is why they have protocols now in emergency rooms. You can't play around with it. It's mostly from infection. They have a fever, it's not getting better, so look up the symptoms to review of what septic shock symptoms are, or even the precursor of that. You get a blood draw and your white counts up. You have to have that a red flag in the back of your mind. We don't want this patient to go septic. This patient needs to be treated. So what you're going to treat with is, well, obviously fluids. This person needs fluids. If they're in septic shock, again, you're not getting your organs perfused. So electrolyte imbalance. So fluids, antibiotics. Those are the main things. Okay, and in a minute I'll talk about the most important thing. We also talked about neurogenic shock already. You need to try to treat the cause of that. So all of these you're going to treat the cause. All right, but remember the most important thing, the highest priority of all of these, right? What are you going to do when the patient first comes in? Or you discover that someone's going down quick? Oxygen. So oxygen, because remember, ABC is your airway. And then also with shock, remember your body tries to compensate, so it does try to preserve the brain and the heart while other organs will decrease. So your brain may be working, your heart still may be working, but you're going to see that BUN and creatinine rise. The urine output's going to be decreased. So think kidneys. Kidneys are a really important precursor or a red flag, as I said before. But look for, remember, they're supposed to be urinating at least 30 cc's an hour. If they are, then okay, good. Monitor that BUN and creatinine. If that's starting to rise, then that needs to be a red flag. Okay, so now let's talk a little bit about mean arterial pressure. So we're kind of going back to vasopressors, but regardless of any of these people here are going down into MODS, all right? Not SIRS, because remember, SIRS has to do with sepsis. That's a systemic inflammatory response syndrome, so it's really have to do with sepsis, but anybody can go into multi-organ dysfunction failure or multi-organ failure. And these people need vasopressors, which I had mentioned earlier, like your phenylephrine, epinephrine, vasopressin, dopamine, dobutamine, or the inotropic ones, but just know the names. And why? Because we need to keep that mean arterial pressure up. What does that mean? So we have MAP. Let me just get a different color here. Can you see up there? All right, MAP, mean arterial pressure. All right, because we want to reperfuse your organs. And so the MAP score or MAP number is very important to tell us if your organs are being perfused adequately. So the mean arterial pressure means increased perfusion to the organs. All right, remember, it's that tissue perfusion that is the key of shock. So the mean arterial pressure should be between 60 and 65. If you see a MAP of 45, you know that that's not good. All right, then you may need to add another pressor agent. If that's already maxed out, you go to the next one. Or you can go to another one until you're maxed out on all of the pressors that are going through the IV. And if those all fail, this person anyways is in critical condition. But if you've gotten where you have all three going at the max and they're not, and their mean arterial pressure is still low, then that's their mortality is very high. All right, so think of, understand what the MAP means and why, and it doesn't improve, then you give a vasopressor. Okay, SIRS and MODS. All right, because remember, SIRS has to do with sepsis because your body's going through a systemic inflammatory response. You've got interleukins involved, different parts of your immune system. So that's SIRS. The whole point is you don't want it to go to severe sepsis because then you can start going into organ dysfunction, the MODS. All right, so you've got to watch that urine output. You got to watch the BUN and creatinine because when organs start to dysfunction, you will start to see damage by your labs, especially the kidneys. What is creatinine? Creatinine, it's a byproduct of muscle metabolism. All right, so it's normal to have creatinine, but it has to be normal. If your organs are breaking down, what's going to happen? That creatinine is going to spill right into your urine. All right, one more thing, or I think one more thing. Absolute. I think I want to try to show the screen to you. Let's see if I can. Try this. No, I guess I can't. Okay. I'll try to post it. Okay, so anyways, absolute shock versus relative shock. So remember, you have a normal fluid volume, you and I right now. All right. If you have an absolute hypovolemia, which would be absolute shock, you're losing a lot of blood. So you're not normal volemic anymore. You're hypovolemic because you're losing too much blood. All right, so that's absolute hypovolemia. Now with relative shock, you may not be losing blood at all, but yet it's called relative hypovolemia because you have an imbalance in fluid volume because your fluid volume versus your blood volume is imbalanced. You have electrolyte imbalance due to just lack of renal perfusion or tissue perfusion in any of your organs. So that's when you want to increase the volume with absolute by giving fluids. But if you have relative hypovolemia or relative shock, then you give vasopressors. All right. So some examples. Hypovolemia, relative, is usually an inflammatory response or for medications. So that's it. Relative is just that. Absolute is from an acute blood loss. Think hemorrhage. Think insensible, excessive water loss. You're urinating too much, etc. So absolute, you're really losing the blood. That's how I think of it. It's leaving somewhere. And relative, you're not really losing the blood, but you're blood or fluids, but you have an inflammatory response going on in your body, which is making it seem like you have an imbalance or you're losing blood, but it's just an imbalance in your cells because you're not getting perfused adequately. Okay, and that's all I have on shock. I'm sorry for the long video, but sometimes just going over it helps. These are very important tips, okay? Take care.